Hello everyone and welcome to the mini plenary session Who Solved COVID on day 2 of the Actuaries Summit. My name is Hoa Bui and I'm the chair of this session, and it's a pleasure. As you know, 2 years ago the pandemic began and it changed the world forever. I remember 23 of January very, very well. It was the day we experienced the first lockdown when Wuhan was locked down to contain the virus. Never before in our lifetime did we have millions of people in the world locked down for weeks at a time. On the positive side, never before did we have the human race develop and test and roll out vaccine as quickly as we did. As we start the summit this year, the picture is much rosier than in 2020. Most developed countries have now been highly vaccinated. And from the 1st of May, many have now relaxed most of the COVID restriction. But as we learn to live with COVID, it is useful to reflect and consider what were the lessons to take forward. For viruses are not going away, they simply mutate, as you know. These sessions explore the question of who actually solved COVID. Was it the scientist who developed the vaccine? Was it the government who provided leadership and fiscal support? Was it the people who voluntarily reduced their own movement? Or is it the simple measure of washing your hand, wearing your mask, and maintaining social distancing? To help us with this discussion, we've got a distinguished panel, a distinguished international panel, each an international expert in their own right, each bringing a different perspective to the discussion. Firstly, Professor Catherine Bennett. Professor Bennett's career in epidemiology and biological anthropology cuts across university and government sectors, including outbreaks preparedness and responses with New South Wales Health and the Australian Government. After working as Olympic Public Health Coordinator for Northern Sydney, Catherine returned to academic and has been the inaugural chair of epidemiology at Deakin since the late 2009. Her research focuses on community transmission on infectious diseases. Catherine is involved in a range of COVID projects, including excess death, public health communication, contact tracing methods, and COVID safe protocols. Catherine has been a leading public expert during COVID-19 responses, keynote speaker and advisor to industry, governments, and institutions globally. Welcome, Catherine.
Thank
Douglas
you.
R.
We're all good to go?
Douglas?
No.
Oh, sorry.
She's going to introduce herself.
Yeah.
Douglas Arles. Douglas initially joined Platinum in May 2003 as an investment analyst covering industrials and as a primary communicator for advisor presentations. He previously worked for CBA as product actuary, and prior to this as an investment manager for Aegon Asset Management in the UK. Douglas left Platinum in October 2008 to work in Singapore, where he helped develop Standard Chartered Bank's equity broking business. He rejoined Platinum in February 2013 as an investment specialist, acting as an intermediary between the investment team and the Australian New Zealand-based advisors. Over time, he built a team to support this effort, and since 2017, he has in addition been introducing Platinum to the US market. Douglas was appointed head of investment in March of 2022 and is responsible for the investment team's process and people. He's been a member of the firm's management committee since 2013. Welcome, Douglas. He is, of course, part of the Actuaries Institute COVID group and is a familiar faces for many of you. Roseanne Harris, welcome, Roseanne. Roseanne is coming to present virtually, as I am chairing virtually. Roseanne is a health policy actuary with Discovery Health and an adjunct professor in the School of Statistics and Actuarial Science at the University of the Witwatersrand. Excuse the pronunciation. Roseanne has over 27 years of experience in the South African healthcare and employee benefits field. Her current role involved industry engagement at a high level, including regulators, government, civil association, industry, and supranationals. She has participated in the NEPLAC engagement on national health insurance, as well as presenting evidence and analysis on the health market inquiry of the Competition Commission. She's been a member of the B4SA funding workstream working group on the vaccine rollout program since the beginning of 2021, and a member of the COVID-19 working group of the Actuarial Society of South Africa. She served as the president of the Actuaries Society of South Africa for 2016 and 2017, and was previously chair of the Healthcare Committee and NHI Task Team. She is also the president of the International Actuarial Association for 2022. Welcome, Roseanne. The format of today's session is that I will ask each of the panelists to present, and then we'll have questions at the end. As you are listening to the presentation, you can ask your questions either virtually or you can do that both if you're attending virtually or in person. So I'm looking forward to this, and I'm going to ask Catherine to start.
Thanks, Hua. And thank you for having me at your summit. So I'm going to talk about the data from an epidemiological perspective and skirt around some of those other questions about how we're doing and what we can put our success down to. Because no matter which way you look at it, Australia has done well. Doesn't mean we couldn't do it better and that we haven't got a lot to learn. And what we learn is going to depend on us having building the data sets that we can do the analysis, because at the moment a lot of really rich data is out there, but not always in a format that allows us to ask those questions about what worked best, what could we do differently, what could we be more focused on in future, more surgical in terms of interventions. So I'm going to start just by talking about some of the data. You're numbers people. You would have been, like the rest of the world, looking at those case numbers reported daily. As an epidemiologist, we talk about the epi curve, so the plots of cases. These vary in outbreaks because the quality of data varies, but that's absolutely true for COVID as well. Normally we report infections by onset date. This was by report date. This is the data for 2020 in Victoria. But equally, we're only reporting the cases that we know about. And in fact, there's always cases you miss. There's people that didn't test positive, or where the lab mucked up the results, or something else was going on. So we had quite an active testing program in 2020, and people often talked about the difference between the first and second wave. So this was one of the first bits of conversation. What could we learn from the first wave? Well, not a lot. They were imported cases, we didn't have community transmission, they were older people who'd come off cruise ships mainly. But that's actually not true. We did have community transmission in the first wave. And in fact, we had no program to test people in the community, even if you had symptoms here in Victoria. So in fact, we were deliberately only focused on very unwell people. You had to be in hospital with a community onset pneumonia, it's very specific, to actually be tested potentially and reported. And in fact, we know not all of those were probably reported either. So in fact, we didn't have a complete picture of the first wave, and we underestimate both number and also the type of transmission. So reported cases is a thing we always think about as epidemiologists. And I'll usually put reported in front of any conversation about those case numbers that come out of health departments every day as an active reminder that there are these drivers that determine whether or not your infection gets captured or represented in the system's data. So we know not all cases of infection with COVID actually have symptoms, and the numbers vary from 10 to 80%, depending on which study you look at. But at least it's going to be 20% of cases don't have symptoms. And now that we don't have any active follow-up from exposure sites, or you're not a contact of a contact, who has to get tested, unless you have symptoms, you're less likely to test. Only if you're in a household with a known case might you do that. So in fact, we have a different pattern of testing, whether you're symptomatic, say 80% of people, or not. We know even if people have mild symptoms, going back as far as 2020, They said only about 50% of people in government surveys said they would test. So all the way through the pandemic, we've had a lot of people who just don't come forward for testing, if it's mild, if they're not anxious about their own health. On top of that, we know that even if you do test, you may not end up getting a true positive. So certainly if you do home testing, you'll have some false negatives. So in fact, that's another problem with testing, particularly with home testing. And if you test at home, you also might not report it, even if you do get a positive result. And it varies at different times, whether there's a disincentive or an incentive to report, whether it's important so you can work from home, so you need to have that record, or it's going to trap everybody you know at home with you and you don't want to do that to them, so you might not test. So you have to understand the dynamics behind testing. So if you go through that process, it's only the green ones, the light green, people who went for PCR testing because they're older and vulnerable to serious infection, or people who home tested and did report. If you look at the asymptomatic, a smaller proportion of those fit into those green categories because more people just aren't testing, they're unaware they have an infection. And if you add those up, you don't even get to 40% of actual infections. And those numbers are probably pretty good. They come off surveys, they came off the New South Wales estimate of the proportion of RAT tests at home, rapid antigen tests that are reported. The other number that we talked a lot about in the outbreak was this reproductive number, and the effect of reproductive number is that changes over time with the interventions you have in place. These were my data from Victoria and New South Wales during the Delta wave, blue Victoria, green New South Wales. So the solid lines are the case reports and the dotted down the bottom are the reproductive number. If you assume that we're hearing only about a fraction of actual infections, but if you can assume that that proportion of infections you know about is reasonably consistent as a proportion, then you can still look at how the cases relate to each other over an incubation period. So 1 week to the next, or in this case, 3 to 4 days later, what were the case numbers doing? And in fact, they were very consistent all the way through, sitting after they initially settled down for a long time around that 1.3 mark, 30% more cases each incubation period, each 3 or 4 days. So the numbers were going up, but actually it was a controlled outbreak. And when you look at the numbers, if anything, while that middle period under the big high case number curves, our restrictions did ease a bit, not formally, but informally. People started to move away from the rules a little bit, and yet our reproductive number, our control, continued to get better. And that was our vaccination rollout. But it is important to remember that the reproductive number is an average. We're looking at that usually at state level, and the sorts of numbers that the modellers use when they put into models are often based on a city, a dense city. But even within that, there's a lot of variability in how the virus moves through a city, and we forget that when we're looking at state level or doing this very high level modelling. Another aspect of COVID is cluster transmission. So it's not that every person does infect 1.3 other people. Clearly, it's one person infecting 10 and a couple infecting nobody, and you get to an average of 1.3. So it depends. You can have the numbers rumbling along in the background, but every so often someone's in a workplace where it sparks, it's an incubator for infection. And that was certainly true during the outbreaks where we were following every cluster to understand what was happening. And once you have a cluster like this and someone takes the virus home and someone else in the household takes it from another workplace, you get these ongoing driven wave. But the other point is that your outbreak is broken down into multiple outbreaks. So when you're looking at case numbers in the second wave, this is New South Wales and Victoria, most were in Victoria. But you can see in the first part there are a lot of different parts of the city and part of our residential services and our occupational areas and schools all impacted. The different colours stand for, the purple is healthcare services, the green is meatworks, which we learnt were a high-risk setting for transmission. But the blue that dominates is aged care. And in fact, by halfway through, certainly the last third, 2/3 of cases, a third of them were either residents or workers in aged care, and the other third of all the cases in the state of Victoria were the household contacts, direct household contacts of those workers. So you can see we still had outbreaks around the edges, but we were in lockdown really to limit the risk of transmission rather than actually stopping transmission, because it was constantly being reseeded out of aged care, and people often still don't appreciate that. And you need to understand it to actually know how to work on your next outbreak or going ahead. The other thing that's variable is where the outbreaks occur. This shows our hotspots. This is from the current data out of the Omicron wave, but it looks exactly the same as the data from the Delta wave and from the second wave in Victoria as well. Northern suburbs, northwest and southeast. And this is the area where we have a lot of very vulnerable people who are often casual workers. You've got extended households, big share households, lots of kids, all things going on that actually give these areas a different transmission potential. So the reproductive number in these areas will always be higher than it is in others. And of course, it's also linked to advantage and disadvantage. And this was from the second wave, where you can see with the red colours being the least advantaged LGAs having the most cases. And that's because they were seeded there in the first place. You can see that around the 19th and 12th of June, where the workers, casual workers from hotel quarantine, unknowingly took the virus home to their communities. And then it took off, driven by this higher transmission potential. So when we did the modelling, this is the Burnett modelling looking at coming out of the Delta wave in September last year, they try and piece it together based on estimates of reproductive numbers that are averages and these case numbers which are fraught. And it's the best we can do. It's important to compare different scenarios to see which might be safer, which not. But when it came to predicting numbers, particularly hospitalisations, it was really difficult for the modellers to do it. And I think a lot of people then were disappointed if it didn't work. But in fact, it just shows how difficult modelling is in these settings, particularly when the raw numbers you're using aren't great. And this was looking in New South Wales at the 12 LGAs of concern. They were tracking, they could predict the reported case numbers pretty well. But in fact, when they looked at the hospitalisations, this kept going where they were completely out. It was nowhere near that, what they were expecting. So it was a good news story, because actually what happened with that outbreak was this incredible rapid increase in the vaccine rollout. And finally, just to reiterate this point, the modellers, the Doherty modellers, did some work looking at how that reproductive number varies across different areas. And if you look at somewhere like Fairfield, which was a hotspot in that Delta outbreak, and every outbreak they've had pretty much, you can see that actually you start off with a higher reproductive number, and when you put all the things in place, even getting up to 80% community vaccination coverage, you still have more work to do to bring this down to a level where you consider that outbreak to be controlled. So it's not that these people aren't doing as well as other areas, it's just that they've got a greater challenge to fight. And I'm just going to finish up then talking about where we are now. This is looking at the new variants emerging. The green line that goes up most steeply is your Omicron. And you can see how quickly that took off. When it took off, it immediately dominated all the other variants present. And when they looked at the serial interval, the time between a case and that person's contacts being infected, that's even tighter. So you've got less time to act. So a lot of the things we did at a population level to control the virus don't hold in these situations, because you don't have time to get to contacts and isolate them. The top curve shows this case numbers again. Again, this is now looking Australia-wide over the last 6 months or so, and you can see what Omicron did. It not only, threw our case numbers up at a rapid rate, particularly in young adults, but it actually made Delta look insignificant. You can't see a bump in October, and yet we had our highest to that point numbers in the country. The graph below, though, is hospitalisations, and you can see how big Delta was in terms of the impact on hospitals. Not as big as Omicron, but actually, there's not that much difference in ICU. And in fact, the reason the Omicron number is high is because you have incidental infections in hospital, people going in to have a baby or because they fell off their bike and broke a leg. And we now have up to 5%, possibly more, positivity rates, actual true infection rates in the community. So 5% of people at the worst of the peak would have been going into hospital with the infection. And the difference, though, between the case numbers and hospitalisations, between Delta and Omicron, of course, is our vaccination program, particularly boosters. That also helps suppress transmission. but also treatment. And these are the two areas where we're talking about who's done what to help us control this. Actually, vaccination and treatment, and putting those together, rolling it out, and everyone in the community participating have been a big part of it. And finally, from an actuary point of view, the other thing to think about is the base rate fallacy. When we're communicating, people don't understand if they have more vaccinated people in hospital than unvaccinated people. It takes a lot of work to try and help them understand that that's actually a tiny percentage of a massive population of 96% adults vaccinated compared to a tiny proportion of unvaccinated people overrepresented in hospital. Spent a lot of my time working on this. And these are the data now taking that through to deaths, trying to help people understand the deaths data. So this is COVID infections, all deaths in Australia. And you can see that over the period, when you go, your winter months is always when we see our higher deaths. We all know that. But we've had an aberrant pattern because we had more deaths than we'd expect May, June, less deaths in winter, and the numbers have gone up and they've peaked recently, and that coincides with Omicron. But it's not all just to do with respiratory disease. If you look at the broad acute and chronic diseases, you can see we had underreports of deaths over winter. Again, no flu to speak of in 2021, and so on. But when you look at chronic lower respiratory, you see the similar thing. So people who have COPD or chronic obstructive pulmonary disease, again, more vulnerable to flu, not so much exposed. And so we've seen underreporting. We're not going to keep people alive forever. There will be a catch-up with these deaths once you have extended people's lives by a year or two. So trying to take the media through this so that actually a rise in cases isn't always unexpected after you've had a deficit in cases is tricky. And what they're using in the ABS for their denominator or their comparator for past times, they've actually skipped 2020. So we have 2019 and then they add in 2021 for a 5-year average. So it just makes it more complex if you're trying to explain to a reporter what that actually does to the data. Influenza and pneumonia massively dropped over the winter, as you'd expect, but we are seeing deaths rise in cancer through the whole period, which is interesting, but things like diabetes and acute diseases, which might have been also negatively impacted if chronic diseases weren't managed well over that time, we might see a higher death rate happening now. So it's a complex picture, hard to unpack. History actually will determine what happens in the next year or two, both in terms of chronic care of patients, but also deaths, lives that have been extended, and perhaps we need to be looking at 3 to 5 year death rates rather than looking at a short period and saying, oh no, this is out of control or it's worse than they thought. What people are doing in the media now is they're taking January's data, which they've just started reporting, multiplying it by 12 in terms of deaths and saying by the end of the year, COVID will be the most important driver of deaths, and that assumes that this rate will stay, we hope it won't, all year, but it also assumes the other rates won't change, and we're not sure about that either, given the disruption that's happened to healthcare. So I'll stop there.
Thank you, Catherine. What a fascinating analysis. I'll ask Douglas now to present and then present.
Thank you. Thank you, Wah. And look, before asking who solved COVID, I think I'll just note that I've just re-emerged myself from isolation over the weekend. So I think my one warning to you all is that if you ever start to believe that you're immune, quickly erase that thought from your mind. I'm quite sceptical of politicians, and I suspect I'm not alone. And I feel quite deflated by a lot of the parochial point scoring that we've had to endure over the last couple of years. And I think our elected leaders' self-congratulations are perhaps, to some extent, unwarranted. So as actuaries, we look at data. I think we all accept that the less we move and the less we interact, the less likely it is that a virus will spread. We also get this further dampening from things like social distancing and hygiene and mask wearing. But at least what I could find early on, it was the mobility data that was most readily available. So quite early in 2020, the data would show that the relationship between movement and virus transmission was quite strong. Stock markets picked up on this. They reacted favourably to places where there were lockdowns. But what we could see here in Australia, which I thought was particularly interesting, was that people reduced their movements ahead of restrictions actually being enforced. And early on, using things like Google and Citymapper data, it was possible to suggest that about half or more of the reduction in movement actually happened ahead of the official restrictions. So I think that the idea the government should take credit for the lockdowns was very much offset by a risk-aware population choosing where they could to stop moving. I think where the government did help was that the implementation of a safety net would have strengthened the resolve to stay at home, and indeed perhaps for some groups there were incentives not to actually do any work, given the way that some of the incentive systems worked. The early days of COVID I found very frustrating, having been exposed, I would say, at least to the knowledge of the virus rather than necessarily the virus. But I was skiing in Japan in late January 2020, Chinese New Year. My daughter caught flu and we went to the International Medical Center in Niseko, where there was this fear about the new Chinese flu that appeared to be being brought in. It was 7 weeks later before our Prime Minister, who'd recently returned from a holiday to Hawaii, was actively encouraging people to go to the footy. By then there had been outbreaks in Korea, Iran, Milan and most of the developed world, and the Ruby Princess was still circulating in the South Pacific. For me, working in global markets, what was going on around the world at that time was clear, but Australia seemed, at least through the media, blissfully unaware. Bondi Beach on the 20th of March was packed as companies experimented with work from home, but it still sort of felt that no one was really paying attention. And that's where I sort of got interested as, if you like, an amateur data cruncher, posting data and charts on LinkedIn, trying to get some attention to the fact that what we were facing was quite serious. I think I was really just disappointed at that stage by the media's crude analysis. And Catherine touched on a lot of this sort of the topics that led to my frustration. But I joined the Institute's working group and produced a paper that really just highlighted that community infection rates were much higher than the reported cases that the media and the politicians were sort of slavishly holding on to. So it was whether we were ignoring asymptomatic cases, as Catherine pointed to, or whether we were not testing enough people, we were taking these reported case rates as if they were the absolute truth. And so our paper was put to the CMO and the PM. They disagreed with the numbers we came up with, but they couldn't refute the message that there were definitely a lot more cases in the community than were being reported. And I guess my frustration was that the movement data suggests that the people are good at assessing risk given the data they're presented with, but the data people were being presented with was flawed. So what I wonder is, would we have stopped moving even quicker and would we have become even more risk averse had we had the correct information? So Hua asked us to look at three areas. She asked us to look at health outcomes, strategy and the economy. As a markets person, I'll start with the Australian economy. And look, if I look in GDP terms, we're pretty much back on the pre-pandemic trend. You can look at the trend GDP and what we might have missed over the last couple of years, and it looks to be approximately $80 billion in 2020 and about $30 billion last year. So that's 4% and 1.5% perhaps set back to GDP, or about a 5.5% hit in total. That sounds okay given the seriousness of the pandemic, but it doesn't really think about individual people's situations. So it's a very general and dispassionate number to come up with, but importantly, it didn't come for free. So if we go back to weeks before Wuhan, Josh Frydenberg stated that net national debt would be 2% of GDP by 2030. In March, just 4 or 5 weeks ago, he forecast this number would be 27% by 2033. So effectively, the pandemic has cost us about 1/4 of GDP, which is $500 billion in today's money, or $20,000 for every Australian man, woman and child. And that's our shared burden going forward. So that's effectively the real economic cost of the pandemic. I think on strategy, it's really hard to criticise the early policies around border closures. They were globally adopted, but we did seem to follow the actions of others, including New Zealand. So I wouldn't say we were ahead of the curve, I'd just say that we did the right thing. I think more critically, we could look at the decisions to reopen the borders and the timing around that and link that back to vaccination rates. The key was getting started. And here we lagged the US and Europe by 2 to 3 months. And I'd say that that was avoidable. It came down to placing orders with the right suppliers. And that delay, I would say, exaggerated the duration and the severity of the 2021 lockdowns. So the cost of the delays to the vaccine rollout was about 3% to Q3 2021 GDP. And it was no surprise that strollout was the Australian word of the year in 2021. As a country, we fell from the front of the queue to no longer being in a race. And I guess the measure of this was the Prime Minister's approval rating, which went from +30 to -10 during the course of 2021. So it's clear that the people thought the delay was a policy failure. Trust was eroded as the public was faced with a lot of mixed messaging and a lot of that sort of infighting. But if we look at it critically, it was simply a delay, and today we are close to fully vaccinated. So the costs ultimately were the Q3 economic, social, mental health impacts, and perhaps the Prime Minister's job. So I'd question the border reopening ahead of Christmas, the timing around that, but again, we're talking in the order of days rather than anything else. It just led to overwhelming the system with Omicron, as we were unsure of what the mutations were likely to do. And it felt like we just went a little bit too quickly and a little bit too doggedly. But again, we're talking here in terms of days rather than anything more significant. And we were lucky that the mutation, although more contagious, was ultimately milder and clashed with a much more heavily vaccinated population. I think what we did get hurt by was the parochialism, the federal against state politics. It was the Warwick Daily News which reported that the actions of state governments in maintaining their own border quarantine restrictions was rapidly producing a crisis in the affairs of the Commonwealth. The only problem was they reported that in 1919 in response to the Spanish flu. So, as Catherine says, we need to learn, but perhaps we never do. Look, to health outcomes, how do we do? There were lots of factors. It's hard to look at them all, but it was density, climate, health systems, our lack of land borders, and probably I think most overlooked in our apparent success was the starting point, that we had a much lower viral load when the global borders shut. Perhaps New Zealand is the most comparable nation, and we're currently running about double the number of deaths per head of population. So it's always hard to say what is the context, but I think people agree generally we ended up with a pretty low death rate compared with most places in the world. Look, during lockdown, I read Viktor Frankl's Man's Search for Meaning. It's about life in a concentration camp. It's about the slow adjustment to freedom that we make after, if we're ever released from captivity. And what interests me looking at the data today is if we observe in February 2022, overseas trips by Australians are 85% down on 2019. Now, I grant you there is a supply issue with flights, but what is really interesting, despite being trapped on this island for 2 years, there are more than 50% higher level of arrivals coming into the country than there are departures, which suggests that we're not in a rush to leave the island despite being 2 years of being cut off from the world. What's interesting, Australians see themselves as laid-back larrikins, and we very much, despite that, followed the rules. And I think others overseas found this quite hard to comprehend. I've been in America a couple of times, and people ask us why we weren't rioting in the streets. But is this really a surprise? In 2019, before COVID, the ABC conducted a survey to find out what were the key attributes of being Australian. A number one attribute of being Australian is following the rules. Specifically, it's respecting Australia's institutions and laws. So is it any wonder that we complied with wearing masks and being peacefully locked down, even with case and death rates before Omicron that baffled the rest of the world? As an investor, I'll finish briefly with markets. In January 2020, the Chinese market provided the playbook. Their market fell over 10% around Chinese New Year, and they started climbing again when it was clear that lockdowns would slow the spread. The playbook in Western markets was very similar. It was to buy when the major lockdowns reduced uncertainty and fear. The American S&P index fell 1/3 between February 20th and March the 23rd, 2020, from what already appeared exuberant levels ahead of COVID, although we are much higher today. And it's interesting to see again in China at the moment with the lockdowns that's having, or uncertainty around COVID, that's been having a dampening effect on that market as well. The amount of stimulus pumped into the system is now manifesting itself in the strongest inflationary pressures in decades, and this is causing investors to ask if we're reversing a 40-year trend of lower interest rates, and we'll find out here today if that's indeed the case in Australia. The other interesting real-world elements were the pull forward of demand for physical consumption as services were put on hold, but aggregate incomes remained supported by governments, and the accelerated adoption of technologies such as Zoom, which had previously struggled for a use case. We wouldn't have been able to hold today's session, or we'd have been unlikely to hold today's session in a hybrid manner before COVID. Meanwhile, the 5-day week, the suit, and certainly the tie have perhaps seen their demise accelerated. One thing is for sure, it will never be the same again. Thank you.
Thank you. And now I'd like to ask Roseanne to give us her perspective on the issue.
Thank you, and hello everyone, and thank you so much for this opportunity to be part of the discussion today. My talk is a little bit of a blend of the IAA view from the profession's perspective, and also some insights from Discovery Health in South Africa. So I think my slides are going to be put up on the screen. Not seeing them just yet. Great. You can go on to the next one. Thank you. So the COVID-19 pandemic has certainly demonstrated the fragility of the global economy to unexpected risks. These risks have manifested in massive human and financial impacts and have led to some robust debates around policy priorities. It's actually incredible how quickly this became such a polarizing issue. Of course, risk management related to demographic risk is a key role for the actuarial profession, and we needed to respond rapidly to work with data that was difficult to verify and validate and was changing rapidly. And we were also very dependent on external expert inputs in interpreting the data, which were also being rapidly updated. Decision-making for any government was a nightmare of limited data and loud voices, and the need to weigh up the risk of human and economic consequences, a real no-win situation. Next slide, please. So early on in the pandemic, the concern was that rising caseloads would overwhelm health systems, exacerbating mortality risk. This was the primary motivation for lockdowns. What we know now is that there was also knock-on effects for access to care for other conditions. As COVID-19 spreads, there was a need to fund treatment as well as PPE for widespread use, and then of course the vaccines as these became available. There was also emerging debate on the extent to which insurance pools were covering pandemic risk, particularly in respect of business interruption, and this exposed a number of protection gaps. And broader economic ramifications hit as some sectors were more impacted, particularly the hospitality and travel sector, with consequences on employment and social security support. We're still facing great uncertainty regarding the health impacts of long COVID and delayed access to care. Next slide, please. So rapid and responsible data analytics played a huge role in the effective COVID response. It was critical to understand who was most at risk and how this could be mitigated. At Discovery Health here in South Africa, our actuarial team was able to rapidly develop a resilience index by May of 2020, using a combination of the WHO resilience factors and additional insights from our emerging hospitalization data. Using this index, we were able to dispatch pulse oximeters to those most at risk during the first wave. And the published analysis on this initiative substantiates that this rapid analytics had a material impact on saving lives by detecting hypoxia timelessly. This demonstrates the need for us to be agile in how we gather and analyze data in order to deliver on our professional promise of protecting the public interest. Next slide. So let me now share some of the South African experience with COVID. Firstly, on the health outcomes. So next slide. This analytics comes from my company, Discovery Health in South Africa, where we cover just over 4 million lives. But the experience of the waves for the national population followed a very similar pattern of experience to the covered population. although there were major differences in access to testing and treatment, which meant that the case reporting rates were quite different. If you look at the graph on the left-hand side, the blue line is the reported cases with the scale on the left axis, and the shaded area indicates admissions with the scale on the right axis. We've gone through 4 distinct waves with hospital admissions rates much lower in the 4th wave. In this last week, we've had again started an experience in an uptick in infections, but with very low levels of admissions and deaths. And the graph on the right shows the reducing trend in case fatality rates over the waves. And next slide, please. As I noted, we have high levels of underreporting. This graph shows the reported deaths from natural causes over the epidemic, with the pattern following the waves of COVID. If we assume that 90% of the excess natural deaths are due to COVID, then we get an underreporting factor of 2.8. And that puts our death rate in South Africa at over 4,500 per million. Next slide, please. Another area where rapid analytics has added value is in the vaccine program. In South Africa, we worked in collaboration with the Medical Research Council to conduct analysis on the vaccines that we were able to eventually access for South Africans. I say eventually because it was a real struggle for us as a middle-income country to compete with wealthy countries pre-ordering many multiples of their population needs, but also not able to benefit from COVAX support. In the end, we developed a unique public-private partnership model led by the National Department of Health for procuring and rolling out the vaccines. And the actuarial profession played an important role in financial modeling and risk-based sequencing, as well as this analytics on safety and effectiveness. So next slide, please. So we were even later to the vaccine party than Australia, and despite the vaccines being consistently available at public and private health sites, our take-up rates have plateaued. Fortunately, we do have good coverage of the elderly, which has been really valuable in keeping mortality rates down in the 4th wave. Next slide. We estimate that we have around 70 to 80% of the population with some level of immunity, either from prior infection or vaccination, or better still, both. Of course, this immunity from prior infection comes at the cost of exposure to COVID illness and long-term COVID effects, and the duration of this immunity is a big unknown. But nevertheless, next slide, this has enabled us to emerge somewhat from COVID lockdown, and recent cases rising indicate the uncertain duration of that immunity protection. There's a lot of uncertainty as we face the winter months, and our booster take-up has been somewhat disappointing. So a big need to just continue to drive the messaging. So next slide, I'm going to touch briefly on what the government response strategy has been. So the next slide illustrates our first case was identified on the 5th of March in 2020, and we went into a hard lockdown from the 22nd of March when a national state of disaster was called. We were one of the first countries to define lockdown levels. These ebbed and flowed with the waves of COVID, and our national state of disaster facilitated rapid decision-making, but arguably not all measures made sense, and not all level shifts were agile enough to balance the devastating financial consequences, particularly in a country with a very limited social security safety net. The national state of disaster was eventually lifted at the end of March, just a month ago, after 2 years, and our GDP, of course, has felt the knocks of contracting last year. So what is our outlook? Let's go on to the next slide. And the next one. Our COVID response has been characterized by extensive consultation. The social partners in this context are government, business, organized labor, and community groups. There's been great collaborative effort, albeit peppered by debate and at times a lack of transparency. The tourism and hospitality sector have been particularly hard hit, and the ability to afford ongoing financial relief is very limited. In fact, just last week, the COVID relief grant was stopped amid quite a furore here in South Africa. I say here, even though I'm in Brussels. Next slide, please. The debacle of blaming South Africa for Omicron had devastating consequences over the December 2021 tourism season. and the propensity for cutting off emerging countries, or along with the vaccine inequality, are key issues to address as we emerge from the pandemic. So finally, last slide. So for the actuarial profession, there is a great opportunity to build on what we have learned through this crisis. And the IAA is able to provide a global platform for professional discourse and sharing these important learnings. This will help to ensure that we're better prepared for emerging risk, and also aids planning for the ongoing implications of what we've gone through. This includes addressing protection gaps in terms of both insurance risks and healthcare access, as well as developing new and innovative frameworks for carrying risk. An interesting development, for example, could be the re-emergence of mutual funds for carrying risks that commercial insurers are more averse to. But in addition to this, we are facing a shifting employment landscape, with accompanying changes in the needs and economic uncertainty at the macro and micro levels. We're still learning about the longer term impacts on health for long COVID, and whether there are longer term implications for mortality risk. Is this a blip? Is it a shift? The IAA Pandemic Task Force will be considering these and other challenging questions, and we'll welcome your input and contributions. Thanks so much.
Thank you, Roseanne. Another fascinating analysis and very succinct. I can hear a lot of commonality in the three presentations: underreporting, denominator issues, catch-up effect on mortality, the economic impact, the vaccine inequality and the cost on less developed countries, the protection gaps, and so on. I'm now going to hand over to Douglas to field any questions from the floor.
Yeah, we have a fair amount of questions, and we're also conscious of time. So what I'm going to try and do is sort of pull together a couple of threads that come out of the questions. They really sort of break into two core questions without trying to go too specific given the time constraints. So the two questions that really come out are a collection around lessons, and they come out around lessons, whether it's things like the supply chain impacts, the impact on lower socioeconomic groups, and what we can then learn both in the context of another pandemic, but also in the context of other areas where interconnectedness matter, like climate change, financial stability, international security, etc. And the other one really comes down to the question of whether COVID will ever be solved, given that not everyone will be able to get vaccinated, the COVID will continue to evolve, mutations, more lethal variants, and so on and so forth. So I think under the lessons, we also like the demonization of the AstraZeneca vaccine and stuff, and whether it slowed the take-up. So really, I think we have two questions. One question is lessons, and one question is, will we ever solve this problem? And so I'll really put that to each of you to sort of wrap up your thoughts around, the key lessons and the ultimate solution. And maybe I'll start with you, Catherine.
Thank you. As I see it, one of the biggest lessons overall is that you have to take the lessons from pandemic response, outbreak response, into prevention. And I don't think we did that. I don't think we learnt from the first wave in Australia because we didn't actively go out and survey what was happening. I know we had limited test kits, but it led to a lot of wrong thinking. The second wave in Victoria was not because our measures in the first wave didn't work. We actually had a completely new reintroduction of virus into the country that caused the second wave. If we'd learnt from the first wave, then we would have probably not gone to as serious a level of restriction. We would have gathered new information on masks, and we probably would have introduced masks. That's what brought our reproductive number down. When we go through cycles of waves and we see different parts of our cities impacted again and again and again, we know our weak points. And that's what you should be focusing on for prevention. But we'd kind of get to the end of a wave and people would be patting themselves on the back. But in fact, we should have been doubling our efforts to actually keep those community partnerships going and being really proactive about what would we do next time differently? How can we support your community? You're most at risk, therefore we're all at risk. And the same globally. We know in advance who won't have vaccine supply, and you have to look to every corner of the world, because there is no such thing as preventing a pandemic by just focusing on your backyard. And that comes to the second question about solving this. It's actually, it can't be solved. It's now a human pathogen that's with us to stay. Very unlikely we will generate vaccines down the track that will allow us to eliminate the virus locally, let alone globally. So it is now having another ongoing issue we have to deal with. But in fact, the way we deal with it overlaps with a lot of the others. It becomes part of our vaccine program, becomes part of our disease control. It's now just a bigger task. But what we've learned from this can help all those other things. We now know how to stop flu, even though we didn't go into this expecting to do that. So you can't stop it forever, but you can control it. So that's the thing, getting down deep into the data and being able to use that really carefully and in very considered, complex, sophisticated analysis to actually plan our pandemic responses in future, but also our ongoing disease control.
Excellent. Thank you, Catherine. Roseanne, do you want to comment either on the lessons or the solution?
Yes, sure. So we have a lot to learn about sharing in our planet. So I think the WHO adage, "No one is safe until we're all safe," has been very apt in this circumstance. And I think there does need to be some introspection on global inequality, both in terms of vaccine access as well as support in dealing with both the financial and human consequences of the pandemic. I mean, the inequality has been evident across countries and also across economic sectors. And of course, uncertainty has increased the cost of capital that's required to keep those hard-hit sectors afloat. I think in South Africa, one of the lessons has been the need to work together. So public and private partnerships have been an important theme in terms of the response. I'm not sure that COVID is solved just yet, or as Catherine says, ever. But I do feel that for us as a profession, there's been an important learning about working collaboratively with other experts. We're not an expert on everything, but we have an important toolkit as actuaries that we bring to the debate. And that toolkit is our technical mathematical expertise, but also our sensitivity and professional promise, as I said, the public interest that drives us in terms of how we apply our skills. So I think it's from the actuarial contribution has certainly been really valuable, but maybe most valuable where the focus has been on the public interest rather than commercial interest. And in fact, the commercial interest has almost followed from benefiting from where we've served the public interest in terms of economic sustainability. So I think in terms of bringing our management skills and being part of a multidisciplinary team, important things to think about for the profession going forward.
That's great, thank you. And I mean, just to sort of add, my own perspectives on it. A pandemic was something that we should have seen in let's say, in the realms of possibility to plan for, and the fear is always that and we saw this, for example, September the 11th when we stepped up airport security, and then we had the shoe bombers, so we start taking our shoes off when we go through airport security. We're always planning for the thing that happened, and the next thing that happens will inevitably be different, as it is with whether the next financial crisis will not emanate from the same set of circumstances as the last one. So I think the other thing is we have to have the right level of focus on what we learned from this in the context of this itself, and what we learned from, let's say, the lack of preparedness in the context of the next X factor or the next event that takes us by surprise, albeit it perhaps shouldn't. So that's my 2 cents to add on the end. Back to you, Hua.
Thank you, Douglas, Catherine and Roseanne. I've learned so much in the succinct session that we had, and it remains now to us, our audience, to rate the sessions and also to thank our speaker for an outstanding panel of experts. Thank you very much to Catherine, Douglas and Roseanne. And perhaps we haven't solved COVID completely, but we have taken a lot of valuable lessons, and I think that we can take forward for the next crisis that will inevitably happen. So thank you very much, and I've very much enjoyed having the diversity of perspective. Please join me in thanking our speaker.